Last week, the New England Journal of Medicine published a pair of articles in its Perspectives series on Congress's solution to the ongoing doc fix problem in Medicare reimbursement. I hosted a discussion online for Medstro, which can be seen at medstro.com. That's medstro.com. I've adapted that discussion for use here in clinical conversations on the theory that this audience cares how it will be paid for its work. It's a contentious discussion among several parties, whom I'll identify for you when it helps to sort out who's speaking. Here we go. Welcome to this Medstro discussion on the end of the so-called Medicare doc fix. The discussion will center on the solution, and remember, it's a political solution, to the problem of trying to bring Medicare spending under control. The New England Journal of Medicine has just published 2 essays on the subject in its Perspectives section, and we're fortunate to have the author of one of these perspectives with us. Dr. Meredith Rosenthal is professor of health economics and policy at the Harvard School of Public Health. Also with us is Dr. Josh Umber, the family medicine practitioner from Wichita, who practices concierge medicine. We have also Dr. Bob Berenson, an Institute Fellow at the Urban Institute. He has an interest in payment reform. We also have Dr. Howard Beckman, Medical Director of the Rochester Individual Practice Association, and a clinical professor of medicine and family medicine at the University of Rochester. Also, Dr. Jeffrey Clow, an assistant professor of medicine at Duke. We also have 2 medical students who will be making their livings and paying off their student loans under the new system. They are Christy Hawley, 4th year at George Washington University, and Molly Siegel, 4th year at Harvard. Welcome to all of you.
It's great to be here.
Rosenthal, your essay gives a kind of a potted history of the doc fix and the solution that Congress came up with. To simplify things, let's call the old sustainable growth rate scheme of the past roughly 20 years the old system, and the new merit-based incentive payment system the new system. That way we won't have to resort to alphabet soup. So, Dr. Rosenthal, you're an economist. Does the new system of reimbursement make sense economically?
The new system is really trying to bring individual incentives into the payment system, and so it makes sense if what we're trying to do is use this payment system to influence both the cost and the quality of care that individual physicians deliver. So I think the rationale for the old system was a little different than the rationale for the new system, but clearly the old system didn't make sense for even the rationale for which it was designed.
Dr. Umber, I assume that the Wichita Business Journal was accurate in describing you as someone who doesn't take health insurance, and thus Medicare. Is that right?
Correct.
Okay. Then as a non-participant in the new payment scheme, what are your thoughts?
I think it's more of the same. I think it is, like you aptly said in the intro, a political answer to an economic problem. So I think it's already behind the 8 ball from the start because it doesn't do actual specific things to cut the cost curve versus a model like ours where we insure less. Even Malcolm Gladwell, well-known writer, has recently said on an interview that we should probably have less insurance. Insurance, by definition, is meant for major things. We don't have car insurance for gasoline, oil changes, tires. Why have health insurance that tries to regulate more than it needs to? So for our model, we cut out the middleman, we pass those savings along. As one person put it, you turn waste into margin. And there's few industries where there's as much waste as there is in healthcare. So our goal is to use free market principles to show immediate savings for our patients, our employers, our insurance companies. So our model is a flat monthly rate. It's $10 for kids, $50 for most adults, for unlimited home visits, work visits, office visits, technology visits. There's no copays in our clinic. Any procedure that we can do in the office is free of charge. That includes stitches, biopsies, joint injections, ultrasounds, DEXAs like the machine behind me, Holters, spirometry, cryotherapy, lesion removal, minor surgical procedures, all free. And then the innovation that will actually bring the cost of care down to things like wholesale medications, labs, pathology, and DME. So I can get 1,000 LASIKs for $8.33 wholesale. Why are we insuring that? Even after my 10% markup, which we're pretty transparent about, it is less than a penny a pill. I think those are the kind of innovative strategies that will actually show a rapid decrease in the cost of care with much less administrative burden.
I'd like to get Dr. Berenson's reaction to that, Bob.
I understand why docs want to be concierge docs. In primary care, there's actually a rationale for having at least some of the spending occur outside of insurance, at least for people who can afford it. But most healthcare spending and most prices associated with health spending are really much too high, and relying on individuals to start negotiating as in a retail market where other goods and services are negotiated, I think is probably not where we want to go. And it certainly
I would say
primary care, but it doesn't have a role for hospital care, for a lot of specialty care. And I guess the final point I would make, and then I'll be happy to turn it back to you, is that what you described is what I used to practice under 25 years ago, primary care capitation. Private insurers actually can administer such a program, monthly payment, not fee for service. And one of the possibilities you're going to hear later that I'm a critic of this SGR repeal bill, but one of the things I would say in its favor is that they will be testing alternative payment models, and one of those payment models can be some form of capitation or mix of capitation with fee for service. And so I am sympathetic to some of what you said, but I don't think I agree that people want to just be shopping in a retail market.
I would say that the rising growth of direct primary care, concierge, I think, is used by a lot of people to throw baggage at or belittle this movement because they do see it growing so well. Medical Economics reported yesterday that the primary care medical home is probably on its way out to be replaced by the direct primary care movement, because this applies equally as well to a number of specialties, whether it's fee-for-service on the acute care side of radiology, pathology, dermatology, or the chronic care side of endocrinology, pediatric neurology, family medicine, surgery, like Surgery Center of Oklahoma, which is showing 8% savings over hospital-based units. Omada Health, which just had their third round of funding and raised $48 million because their free market-based, consumer-driven approach to chronic care of diabetes has been said if it was a medication, it'd be labeled a blockbuster medication, all because of free market insurance-free attempts to manage healthcare. I think what we have is we have a system designed by bureaucrats, and the only thing it really does well is make red tape.
If I could interrupt, there was a story yesterday in the New York Times, I'm sure you're aware of it, of a drug. I can't remember what the disease is.
AIDS.
That was
antifungal AIDS that the investment hedge fund manager took from a few dollars to several $100s.
Yeah, it went from $13.75 a pill to $750 a pill. I saw an interview with him in which he was asked these questions, and he said, well, we need the money to invest in a better drug to treat this disease. They said, but this doesn't really make any economic sense. If the former owners of the business thought that $13.75 a pill made economic sense, why is it now $750? Does that make more economic sense? And he said that it did to him, and that he wasn't going to change the price. So I guess the free market has got it's as much of a calling card, say, as concierge medicine. It tosses things out into the discussion, but doesn't necessarily solve the problem of the person with the disease who's got to come up with $750.
Just because there's examples of the free market not working efficiently doesn't have any bearing on our progress or results for primary care.
Well,
one bad actor doesn't spoil the bunch in terms of whether free market can help lower the cost curve way better than the government has.
Well, the cure for this disease is now roughly $50,000, and the cure for hepatitis C is now roughly $85,000. And so
let's take a moment to talk about the cure for an incurable disease. So, I granted that $1,000 a pill is a very high price. Malcolm Gladwell, again, noted New York columnist, has said if you want blockbuster medications, you're going to have to allow blockbuster profits to come in and treat something that is otherwise an expensive long-term chronic disease. Now, at $1,000 a pill, he absolutely invites a significant amount of competition, and you can't have the same medicine from overseas for a fraction of the cost. And that is what the market does, is it will drive that cost down. But just like any other significantly advanced technology, it starts off expensive. Good.
I want to take some opinions from the other panel members. Dr. Clow, how do these Medicare reimbursement economics look to you?
Yeah, I think that putting aside any major overhaul, I think in the near future we can expect that we're going to continue to have Medicare in near its current form. I think what's interesting about these reforms is there are actually two options co-evolving. There's the MIPS system, and there are the alternative payment models, which is I spend a lot of time designing and launching. It's easy to be skeptical. You can look at both of them. With the alternative payment models, there haven't been a lot of, there's been sort of modest success. If you look at the precursors to the MIPS, particularly the physician value-based modifier, for the most part, most practices are rated the same, rated as average. But I think there are a couple of reasons to be optimistic about this. First, physicians have gotten what they wanted for a number of years. There's now an end to the SGR, and this has kind of put the onus back on physicians to help develop meaningful measures, meaningful ways of assessing care, either through the MIPS or through alternative payment models. And I think, as we're able to identify actual effective strategies for success, whichever, I don't know if both of these will kind of survive, or if one will become a more effective way for reducing costs, or it could be that neither one is very effective. Then we may be back to broader price cuts to actually control costs, because the problem with Medicare costs isn't going away. And so it's, I think what I'm going to be looking for is how enthusiastic physicians and other stakeholders engage in these models and making them work in a way that actually control costs.
The people who've commented on this have often point to the idea of the tragedy of the commons, which is that there are limited resources, but there are no incentives for anyone individually to be judicious in using them. And you wonder whether, when you look at the new reimbursement scheme, I was trying to make sense of it. I was trying to make sense of, well, who's going to get penalized and who's going to get rewarded. All of those things, all those penalties and rewards go away in 2024, don't they?
Well, I think that the law doesn't speak to what happens before then. I don't think they go away in 2024. I think it's just not clear what happens after then. So the main axis for the merit-based incentive, for the new system, which I really like your word, so for the new system, is a budget-neutral adjustment with penalties and bonuses. What goes away are the sort of extra bonuses for the top performers. That's sort of a one-time only transition payment, as it were, as a way to move to this new system.
Okay, so it's those bonuses that are, I guess, funded to the tune of $500 million a year for this next 5 or 6 years.
Correct.
That's it's a considerable amount of money.
It's probably not a considerable amount of money when you consider there's 1 million physicians. So at best, they might get 500 if evenly distributed. Most will spend more than that $500 attempting to comply with that red tape.
I think you quibble with the numbers a little bit. It's only the top group of the top group, but agreed that $500 million in healthcare is a small amount of money.
Yeah.
So we talk in trillions.
Well, Dr. Beckman, you've got a rather large practice association to manage medically. What are you hearing from your colleagues?
I can't repeat it on podcast, but the thing that's missing is that medicine to me is becoming a team sport, and so the focus on individuals changing their behavior it's not a very coherent model anymore. And so this idea of using analytic data to determine how everybody is working together and coming up with either bundled payments or capitated payments where people are encouraged to figure out ways of doing things more efficiently and using those dollars to either invest in improvement or pay people differently than they are now would make a lot of sense. I think what we're starting to be able to do is to look at quality and cost together and be able to look at for high quality practices what their differential costs are so that people can learn how to deliver the same level of quality at a potentially lower price. That's difficult, I think, for individual physicians to do by themselves. It requires a lot of support.
I would disagree. We have a growing network of hundreds, if not thousands, of direct care doctors who are doing this every day. In-house inventory, 44 states allow physicians to dispense their own medications. Again, I get them for a fraction of the cost of pharmacies. That fraction of the cost of what is billed through the pharmacy. We've gotten chemotherapy for breast cancer 99% less. Literally $600+ for a 2-week supply at the pharmacy. Name brand, our generic, less than $6. Other things like a CBC is $1.65. Medicare pays a lot more for a CBC and then the associated administrative burden. So we can pay for patient care paperwork, but we can't pay for both.
I'm happy for you, but for myself, I personally would rather healthcare be delivered systematically.
Oh, I didn't realize we were talking about our personal preferences. I thought we were talking about a national model.
I'm using myself as a representative sample of the United States. I think the ability to look at systematic care, I mean, this is just a philosophical difference between Josh and I.
But we've tried your philosophical model of Medicare funding a lot of healthcare, and it hasn't gotten us anywhere.
Well, wait a second. Medicare has gotten us plenty of...
Bob Berenson comes in here.
It's an excellent program. Most of the European countries use large payments. Government...
Oh, it's so excellent we have to change it.
For the last 5 years, Medicare spending has been roughly flat. It's provided insurance protection. People need insurance, despite what you are arguing. And yes, there's a role for
astronomical compared to the tax revenue. The tax revenue of that is unsustainable. That's why we had the SGR fix. It is not working out for doctors. That's why doctors are leaving Medicare in droves. It's really not working out for patients. They're not thrilled with the care. Hospitals
doctors are not leaving Medicare in droves.
Yes,
you may be leaving Medicare in droves.
They
Medicare payment system certainly needs to be reformed because it pays too much for procedures and tests and not enough for primary care. Some of us have been trying to fix that. And in fact, my problem with the new model or the new approach is that we do not have the quality measures that will make the MIPS work, but in the meantime, we have a fee schedule that is tilted way in favor of procedures and tests and not primary care and not cognitive specialties, and we can fix that. So we should fix that, but basically, healthcare is not the same as other sectors of the economy. I would urge Josh to read Kenneth Arrow's essay from 1963, which is as relevant today as it was then about how healthcare is different.
I would argue the exact opposite. Healthcare is such a valuable commodity. It should be viewed as a business more so than any other. The problem is that you guys are afraid of running healthcare like a business because somehow we have this flawed moral ethic as a profession that business is beneath us. And I would say that if we take our oath seriously of do no harm, that means do no financial harm either, which implies a strong business ethic to drive the cost of healthcare down. And we haven't been doing that for our patients lately. I can get Imitrex for $200 less than my patients used to pay at the pharmacy. I'm giving them time, money, energy, health back to them for $6.
This is a question for all of you. and I've not been able to discern, to discover the answer. Is the new system based on relative value units at base? Is that how the reimbursement baseline is set? Is it still
yes,
based?
so the underlying fee-for-service system based on relative value units remains.
Okay, so currently the reimbursement board, I believe, is run under the auspices of the AMA.
That's correct.
And it's weighted heavily in favor of subspecialists. That's been a complaint, with primary care having a limited influence in the final voting.
Jump in on that. I agree with the point you're making, but just to clarify, the AMA committee called the RUC, the RBRVS Update Committee, is advisory. CMS defers to, it doesn't have to accept their recommendations, tends to, and that's part of the problem, and that's what I was referring to. We have an evident problem of misalignment of values in the relative value scale, with overpayment for tests and procedures and underpayment for the time Josh spends with his patients.
I'm paid very well for the time I spend with my patients.
Excuse me. Instead of fixing that for people who wish to participate in Medicare, as I think most physicians should do, we could be fixing that problem, but instead we are envisioning new models using some measures that aren't particularly good to claim that we are going to distinguish high-quality doctors from less good-quality doctors. I think it's a diversion of energy and resources away from the evident problem, which is to try to get physicians to participate in Medicare under a better fee schedule.
It's just a cynic's point of view, but it seems like in some ways, some of the worst parts of the old system have been preserved, and I don't blame anyone for throwing up their hands and at least trying to move forward. I wanted to ask Ms. Hawley and Ms. Siegel, who, as I said at the beginning, are going to be paying off their student loans under the new system if they take Medicare patients. Tell me what you see here. There's a new system that's coming in, and do you feel comfortable that it's not yet clearly defined, and the criteria for which for judging performance have not even been verified yet? Do you have any trepidation about jumping into the profession?
Half of the physicians in the United States don't practice in a hospital. So I guess for me, one of my questions for the panelists too is what happens to people who want to operate, and how are you going to have all of the tools that you need, such as all the electronic medical records that you're going to need, all the ability to analyze data to actually provide this information that you need in order to be judged?
Got it. Responding to that last question. Is it Molly who asked that one?
Christy.
Oh, Christy, I'm sorry. I think, unfortunately, one of the untoward or inadvertent consequences of moving to this new payment model will be that most physicians cannot afford to give up 9% of revenues because they haven't submitted the right performance measures in the right format, and it will drive small practices out of business. Many new physicians or recently minted physicians would rather not be entrepreneurs, would rather not be an independent practice, like shift work, and this will speed up the exodus of independent practices. Josh thinks he has a model to preserve independent practice. I wish him luck, but I think that one of the unfortunate consequences will be to drive into larger practices and will give up the personal touch that small practices exemplify.
I think what you'll actually see is just like some smaller hospitals choose not to go JACO certified because it's not worth the cost. The juice isn't worth the squeeze. You'll see a lot of clinics say, you know what, it costs me 10% to do the paperwork, only get my 9% reimbursement. And for every action, there's an equal and opposite reaction. As we saw this in the 90s when hospitals bought up private practices and then sold them back off because they can't run them well. it's happening again, and they're already starting to furlough family physicians who are part of the hospital systems because they're losing the money. And what I've seen is I've been able to hire 3 physicians to join my insurance-free practice in the last 3 or 4 months because all leaving larger hospital-based systems that are now merged to these megaplexes, and the doctors are number, they can't provide good care, they can't get the resources they actually have more support, more time, more ability to care for their patients in an insurance-free model at $10 a month for kids and $50 a month for adults. This is an affordable option that more doctors are going to choose.
Okay, Dr. Rosenthal, my question to you. You've been a close observer of these matters. As we've been saying, politics has played an important part in creating the problem, but also in offering a solution, the solution that we're about to try. I'd like you to go out on a limb and make some predictions about the role of politics in the success or failure of this new system.
About the role of politics in the success or failure as opposed to the economics. Well, I think as we started talking about the plan for the unfolding of the new payment system and what happens when bonus dollars go away, I think where politics will play in is if we do not get to a point when those bonus dollars go away where we have a clear set of measures that physicians view as meaningful across specialties, and where the capacity to report, as we were just talking about, for small practices in particular, is not in place. I think that's when the honey is removed from this payment system and it is really stripped down to the possibility of very substantial penalties. I think that's where we may see lobbying Congress to alter the payment model once again when the consequences may be untoward. And so it's a challenge, not an impossible challenge, but a challenge for the government and the professional societies as well as others in the delivery system to really step up in terms of figuring out how to make this payment system meaningful, so it is not simply random penalties and bonuses, but really meaningful. And I think that really is going to come down to the measurement capabilities.
Okay. Well, listen, I want to thank all of you for a robust discussion today, and I wish all of you success, no matter which form of practice you've chosen, and I hope it turns out well for you. Thank you again so much. That was Clinical Conversation number 185. They're all archived at podcasts.jwatch.org. Thanks to Medstro for sponsoring this discussion as part of their NEJM Open Forum series. Go to medstro.com for other discussions in that series. Thanks also to Kristen Kelly, my executive producer, and thanks to you for listening.